This is Brian Wormers recording a video lecture for non-inflammatory intestinal disease. This is the learning objectives for this chapter. So the first thing we're going to talk about is irritable bowel syndrome. So this is one of the most common digestive disorders in the United States, affecting 1 out of 5 people. There's lots of different classifications as to how it presents. It can either present with diarrhea, constipation, alternating, or a combination of the two. Etiology for this is unclear, but we can use the Manning criteria for this. And basically the Manning criteria is the abdominal pain relieved by defecation or falling asleep. Is the abdominal pain associated with changes in stool frequency or consistency? Is there any abdominal distension? Is there a sense of incomplete evacuation of stool? Or is there a presence of mucus with stool passage? So a flare-up can usually bring the patient into a healthcare provider. It's usually in the left lower quadrant, and you're going to see different things that will bring this patient in. But oftentimes it's pain, it's weight loss, it's mucus in the stool, and just general discomfort. Treatment-wise, some of the things we can do would be increase fiber intake to 30 to 40 grams daily, make them have some regular meals, push lots of fluids from 8 to 10 cups of liquid a day, and then we can start some drug therapies. If it's constipation that there's a problem, then of course we can start on laxatives or adding bulk with your fiber. If it is diarrhea, we can start some antidiarrheals. If it's pain that's associated with this, we can even start on some antidepressants. They can start some complementary therapy such as things to decrease stress. So either ginger, peppermint, lavender, acupuncture, acupressure, etc. The next topic we're going to talk about is herniation. And basically this is a weakness in the muscular wall in which you've got the intestine poking through a little bit. So up in the picture you can see that there's umbilical hernias, incisional hernias, femoral hernias, and these can be either direct or indirect. And so there's lots of different ways to talk about this. Some of the most things would be, or the most important things would be is this reducible? So if you push on it, can you get it to go back through the muscle into where it's supposed to be? Is it irreducible where it's stuck? Or is it the worst thing and that's strangulated, and that means that it's getting pinched off, including the blood supply to that, it's getting pinched off, and so it's going to get necrotic. So treatment of this is going to be, you could either use a truss, which is like an abdominal binder, or think of like an old-time corset, and that's going to put pressure on it so it can't pop through, or more commonly it's going to be surgery. So this can be a minimally invasive inguinal hernia repair or any type of hernia repair. And most of the time they're done and out of the hospital in 3 to 5 hours. So with this, they're going to, you can maybe ice it, especially if it's an inguinal hernia repair. But basically there going to be no weightlifting for a period of time just to allow that to heal. Colorectal cancer, unfortunately, is too common in the United States. Some of the risk factors and etiology for colorectal cancer include age older than 50, a genetic predisposition to this, personal or family history of cancer, a history of polyps, positive for genetic testing of the genes positive for colorectal cancer. Diet modification should be done by most Americans, including a decrease of fat, decrease refined carbs, and an increase in fiber. And then colon cancer screening, often including endoscopy. This is going to be based on age and risk factors. In this image over here, you can see where the majority of the colorectal cancers happen, and you're going to see that over 50% happen from here on down. And the theories that I've heard include that this is where you're going to hold most of your stool. So if you've got carcinogens in your food, then this is where it's going to maintain the longest contact hours with your intestines, and that's why this is such a high risk area right here. So within colorectal cancer, you can see that we might have to take out some of the intestine, and when that happens we might have to do a colostomy, and you can see different types of colostomy here depending on where we need to take out that part of the stool. So this is kind of a unique one in which we've got a double barrel. And basically with this one, you've got 2 pouches. One that's kind of a mucus one right here, and the other one here, which is actually going to hold fecal matter. So common manifestations of colorectal cancer is going to be bleeding, rectal bleeding, anemia, changes in the stool. Can be obvious distension or masses that they can palpate. Surgery, like I said before, they might require a colostomy, but what we're trying to do is remove all that cancer and get good borders from this, as well as removing lymph nodes around that area, making sure that we're getting all of the cancer so it doesn't spread. So as we talked about colostomies, care of colostomies include looking at it. Is it got good blood flow? Does it look good? Are any sections of it bleeding or torn or pulling away from the skin? Is it ischemic or necrosis, changing colors, turning dusky gray or black? All that can be really bad, and you should notify your provider if you see any of that. We should measure the stoma, especially when we're changing appliances to cover that stoma, because we really want to protect that skin around there, because there's lots of stomach acid and bile salts that come out of that fecal matter, and that can really break down the skin around that stoma site. We can do different measures to control gas and odor, some of which are dietary. Other things we can do would be to put different powders or different scents within that bag too, and that can help out. Our ultimate goal is to try and resume normal activities. Even with this colostomy bag, we try and get them out and moving as much as possible. We work with the enteral therapy or stoma team in order to try and get them active. Our next topic is obstruction. It can be from different causes. It can be completely blocked or just partially blocked, leading into a diarrheal type of picture. This can be mechanical, so something physically blocking it, or non-mechanical, such as a paralytic ileus. Some of the things that you can see over here for the rationale for it would be intussusception, where it kind of telescopes in on itself right here. It can be a volvulus, in which that intestine twists. But more commonly, if we're talking about a volvulus, what we're seeing is a twisting right here of the outside of the intestines. Manifestations of this is going to be pain. It's going to be bilious vomiting, so that's that green puke that they might have. Obstipation, which they can't poop. Diarrhea, because the only thing that's getting through is just the liquid, none of the solids is getting through. Or borborygmi. Diagnosis is going to be imaging, so oftentimes we're talking about ultrasound or CT, and that's usually enough to do it, tied with patient assessment. Management of this is going to be making them NPO, putting an NG down to try and relieve some of that stomach content so they don't puke, hydrating them well, pain management, and then surgery to correct this obstruction, if necessary. If it is minor, we could possibly go with stool softeners or even an enema to try and relieve a blockage if it's fecal matter. But for some of these things, this is going to require a surgical intervention. Polyps is a common growth that happens within that intestinal tract. It either can be pedunculated, otherwise sessile, and you can see where these could cause obstructions. Otherwise, it can cause some bleeding as it causes as food and particles are going through there. Most of these are benign, but they can manifest into cancerous and malignant cells. This can be a hereditary trait, but a lot of the times these are asymptomatic. People will have these and not even know that they've got them. Although it can lead into, like I said, gross rectal bleeding, intestinal obstruction, or even intussusception where it telescopes in on itself. Hemorrhoids is a common thing that many patients will have. This is swollen or distended veins in the anal rectal region. This can either be internal, so it's above the anal sphincter and you can't see them. It can be external, which lie below the anal sphincter. Treatment of this can either be non-surgical, such as local, ointment, changes in diet, those type of things. Otherwise, it can be surgical management in which they remove that hemorrhoid. Afterwards, they can have some bleeding with this, and usually that first bowel movement that they have is painful, so it's good to at least warn them of that and let them know. Last one is trauma. So any trauma into that abdominal area can be very traumatic, by definition, I guess. But there's many vascular organs in that area. We distinguish this between blunt versus penetrating. So blunt would be a baseball bat versus penetrating, which would be a knife or a gunshot wound. We can look at the ABC, so airway, breathing, circulation, and see how they're doing with this. We have to watch for shock because you can bleed out tremendous amounts of volume and not have that be overtly obvious, and that can throw them into that shock situation from hypovolemia. Other things we look for would be Cullen sign, which is bruising around that umbilicus, Turner sign, which is bruising on the flanks, a Ballant sign, which is left flank dullness when you're percussing it, and that can be a ruptured spleen, or we can do a Kerr sign, which is left shoulder pain if you have a splenic lac. Treatment-wise, we're really looking at getting some large bore IVs in there so we can place fluids and blood if we need it, as well as pain medications. We're really trying to balance the IV fluids as well as the blood if needed. We're going to do some labs on these patients, so ABGs, CBGs, glucose, electrolytes, coags, all these fun things, and try and manage their fluid status. If it's severe enough, and depending on what imaging shows, we might have to do surgical management of this and take care of any bleeding in the operating room. This concludes this presentation. If you have any questions, please contact your instructor.